So I'd like to start off by thanking the organizing committee for asking me to come and speak with you guys today. I'm very excited to hear about all the things that you guys are doing in terms of antimicrobial stewardship and other initiatives, especially in the realm of veterinary medicine. It is something that I know nothing about, aside from the fact that cats have 4 legs, and that it is harder than you think to give antibiotics to a cockatiel when they are sick. That's coming from personal experience. And just out of curiosity, how many people in the audience are in vet medicine? Okay, and how many in human? Okay, so we got anyone in both? All right, excellent. Okay, make sure I press the correct button. So unfortunately, I have no relevant financial conflicts of interest. I was asked to kind of gear my talk towards those of you in veterinary medicine, giving you the broad overview about what we do in human health and human medicine in terms of antimicrobial use. So hopefully in 30 minutes or less, I'll be able to kind of paint you a good picture of what we do. So a little bit of trivia. We don't have audience response systems, so you can just kind of think of this internally. So I'm a bit of a World War II buff, or I consider myself a bit of a World War II buff. So what fruit from this list do you think helped play a substantial impact in modern medicine and helped save many, many lives through the course of the Second World War? This is a panoramic picture from the deck of the Missouri out at Pearl Harbor. So I'll tell you on the next, let's go like this, next slide. So we all know about Fleming and discovering penicillin in the late 1920s. Turns out there's a rather interesting kind of story behind the scenes about the whole process of that discovery and actually bringing it to frontline medicine, that his initial discovery actually got put to the back of some journals and wasn't discovered many years later by these other 2 gentlemen on the right, Florey and his chemist partner Chain. Fleming really didn't have the chemistry background or the kind of knowledge translation ability to really isolate the active ingredient and really get it into clinical medicine. That's what the other 2 guys did. It was Chain who did a lot of the chemistry behind isolating the active ingredient, but they still needed a lot of broth to get enough active ingredient to actually treat a human being. I think at the beginning they needed something like 2,000 or 3,000 liters of broth to be able to have enough penicillin to treat one human, and they had very weird contraptions with these towers with incubators. They jerry-rigged bedpans into different towers to try and get enough, but they really struggled. And so they did what a lot of people do now when you have a good discovery that you need kind of upregulated and brought to market. They went to the United States with some industry collaboration, and it was actually there that one of their office assistants went to a market. I think they were in Indiana or Illinois somewhere. She went to the market and discovered a bunch of moldy cantaloupes that she brought back to the lab, and the species of penicillin on those lovely golden cantaloupes actually produced 1,000 or 2,000 times more penicillin and active ingredient than the initial strain of Penicillium that Fleming had isolated. And this, through some input with industry in terms of tech development, allowed them to go from the first half of 1942, when they would only produce about 500 million units of penicillin for 6 months, to the end of the war, where they were doing over 600 billion units every month. So really quite a dramatic change from the lowly cantaloupe. And this here I've put, this is the obit of Ann Miller, who was the first civilian patient successfully treated with penicillin for a septic abortion. This is her. She died in her 90s in New York City. So now the narrative has actually changed quite a bit when we talk about antimicrobial use. So now we've heard a little bit about antimicrobial resistance. That is really kind of now at the forefront, and really the lack of further drug development when it comes to antimicrobial use. This picture, we talk about kind of One Health and global medicine. The picture at the bottom with the map is a representation of the air traffic volume between common hubs across the world. So you really get a sense of how easy it is in the course of a day for someone to travel really around the world, and not something that you're going to keep out with the course of building a wall or other barrier. So I want to start off with who prescribes in clinical medicine. So I think from this list, it's important to consider the non-physician prescribers, and really make sure you reach out to these individuals, these practitioners, when you're thinking about stewardship initiatives and what designs you can bring to your jurisdiction and to your setting. So to start off with the obvious example, you do have physicians. And in medicine, really any physician with a valid provincial license can prescribe antibiotics. There's no special training or anything that you need. The training that we do really varies quite a bit, depending if you're, say, in a program like family medicine, that's 2 years of training, up to some of the subspecialties. You might spend 6 or 7 years after the completion of medical school. In the inpatient setting, there might be some restrictions on what you can prescribe, and that's really jurisdiction or hospital dependent. You might need approval by the infectious disease service to actually access these particular drugs. Pharmacists now in many provincial jurisdictions also have the ability to prescribe not only antimicrobials but other drugs. Dentists is a group of practitioners, I think, that kind of got missed in the initial wave of stewardship planning. We have a project that we're doing in Manitoba where we're kind of benchmarking antimicrobial use, and we found that our rates of prescribing in dentists has really increased quite a bit, so much so that in the most recent year they accounted for about 10% of all antibiotic prescriptions in Manitoba. Nurse practitioners, so these are nurses with extensive additional training, and they really function independently on their own. You'll find them in some hospital settings, but primarily they're based in outpatient clinics. This is in contrast to physician assistants, who are individuals who have trained with a bachelor's and they go into a master's program in PA medicine, and they are designed to be a physician extender, to work in consort with the physician. The Canadian military had used them for a lot of years. They can prescribe antibiotics, but under delegated responsibility from the physician under which they practice. Midwives, naturopaths, I've put a star there because they're not a regulated health profession in every province, and even in those where they are regulated, they can't necessarily prescribe. And also, I think BC is one province where where naturopaths can prescribe. And then in Manitoba, we've recently come out with this, the nursing authoritative prescribers, so they can, in certain care areas like travel medicine and reproductive health and diabetes medicine, they can order certain drugs and certain diagnostic tests. And this is data from CARS, from Public Health Agency of Canada, as an estimate in terms of who is doing the prescribing. So the vertical axis differs. So on the left, this is the one pertaining to family practitioners, to clinical physicians, and on the right, because the scale is a little different, that's you're going to be for your PAs and dentists and nurse practitioners, et cetera. So you can see the rates are highest in clinicians, but still substantial when we talk about the other practitioners, including dentists. So where do humans receive their antibiotics? So of course, in the hospital setting, in inpatient use would be one place to think of. This is data from an older retrospective study in the United States looking at a very large network of 40 freestanding pediatric hospitals, and they wanted to take a snapshot in terms of which pediatric inpatients received any antibiotics through the course of their admission. And so over the course of their study, they had 600,000 hospital admissions that they were able to draw from. Figure A represents any antimicrobial use, so roughly 60% of all hospitalized children in this network received some antibiotic at some course in their admission. And figure B is for those that they considered broad spectrum, so in the range of about 10 to 15%. So fairly substantial, and each dot represents a hospital, so you can see there's a fair amount of variability. I'm part of a cross-Canada research network with other pediatric infectious disease physicians where we're doing regular point prevalence surveys in our pediatric hospitals to see which kids are on antimicrobials and for what reasons. So this is some data from our initial pilot program that we did a few years ago. We've now expanded it to all the major pediatric centers in Canada. So our initial pilot was on a couple of different days, including during respiratory virus season when we tend to have a lot more hospital admissions and a lot more antimicrobial use. So this gives you a sense across our pilot centers. So we're in the purple. General antimicrobial use was at the rate of about just less than 40% across all centers. and highest in the areas where you expect patients to be relatively more unwell, like the ICU and the bone marrow transplant and oncology units. And what were they being used for? So common things being common, lower respiratory tract infections and pneumonias, intra-abdominal infections, so for various surgical issues, and then possible sepsis and bacteremias were all very common, but still with some variation from center to center. You can also have a lot of variability in antimicrobial use for specific admitting diagnosis across centers. So this is from that same pediatric network of 40 hospitals that I mentioned earlier. So what they did was look at their network, and they wanted to see, based on care guidelines, which are now the same across Canada and the US, for pediatric pneumonia for kids who are not acutely unwell, so they're not in the ICU, they don't have other comorbid conditions. First-line therapy is narrow spectrum, ampicillin, amoxicillin, et cetera. So they wanted to see how centers were doing with being guideline concordant. So each circle represents a center, and the size of the circle represents the number of diagnoses. So you could argue kind of their wealth of experience with that diagnosis at that particular center. So you would want, in this situation, your circles to be as far to the right as possible, so as close to 100% of the time. And you could see that even at these expert institutions, because they're pediatric centers, there was really the majority of centers were not using guideline concordant therapy, and it didn't really depend if they had a lot of admissions, because some people make the argument, well, perhaps if you don't have a lot of admissions, you're a smaller center, maybe you're not as comfortable with that particular diagnosis, but that really didn't hold true. Here was appendectomy. So the guidelines, including even for adults, are that we don't recommend first-line anti-pseudomonal coverage for patients admitted with acute appendicitis or complications thereof. And you can see that, again, this should be as close to now to the left as possible, and you can see really scattershot. There's a lot of variability across all these pediatric networks, even though they should be, in theory, working from the same guidelines. So now we have inpatient medicine, but that really pales in comparison to the volume and amount of antimicrobials that are prescribed really in the outpatient ambulatory setting, which is where most of the prescribing occurs. Even older data, pediatric data, I do pediatric ID, so a lot of my slides are going to focus more on pediatric information. Estimates from the United States, just in kids, 50 million prescriptions a year, accounting for almost 1 in 5 any pediatric visit to a physician. Unfortunately, a lot of the time, these are overly broad spectrum agents, including macrolides. Common things being common, these are often for various respiratory illnesses, but even then about 1 in 4 are for diagnostic conditions where antibiotics are generally not needed. A nice study that was a bit more recent, this NAMSIS database. These are very good survey sets from the United States that cover about, I think, about a 1/6 or a 1/7 of the entire US population. They include both clinics and emergency rooms, various ambulatory settings. What they wanted to do is get a snapshot of overall antimicrobial use. So they took submitted physician billing criteria, which has its limitations, of course, that's a caveat. And they really looked at prescribing rates based on those conditions. And they grouped their conditions based on guidelines into conditions where antibiotics should always be given, like pneumonia or urinary tract infections, to conditions where you could use antibiotics sometimes, like sinusitis, sore throat, or conditions where really you should never use antibiotics, like acute bronchitis, or if you're calling this a viral pneumonia. And they took that by a general population rate, and they found that just over 12% of any physician visit, this is for kids and adults, resulted in some form of antibiotic being prescribed, most commonly for acute sinusitis. When we look across all ages, all diagnoses, the rate was about 500 prescriptions, antibiotic prescriptions per 1,000 people. Unfortunately, they estimated from that national sample, about 1/3 of all those prescriptions were likely going to be inappropriate. This is from a different study. This is from an annual report that the CDC puts out on estimates of rates of antimicrobial prescribing. And you can see from the heat map that the rates tend to be highest in the southeast and lowest in the west and northwest parts of the United States. So data from Canada, from CARS, from Public Health Agency, which provides a rough estimate based on purchasing information and dispensing information from outpatient prescribing. It really shows us that over the last several years, it really confirms what we already know, is that the bulk of antimicrobial prescribing is in the community, roughly 92%. In 2017, the estimates were about 262,000 kilograms worth of antibiotics at a value of about just under $900 million were prescribed. To put that in perspective, the weight of the Statue of Liberty is about 203,000 kilograms. And then, as you'd expect, there's a lot of variability across the country. So rates have been typically highest in the Maritimes and Newfoundland, and then kind of vary a bit as you move across the country. This was data from an Ontario cross-sectional study where they were able to look at antibiotics dispensed across the province and really to get a sense of what is used in different age groups. And what they found was that, similar to what has kind of been reported in the CARS survey, is that the rate of antimicrobial prescribing over the last few years has been substantially higher in the older patient population, so those over 65, compared to young adults, so those kind of 18 to 64 years of age. And in the older patient group, it tends to be more broader spectrum therapies, trimethoprim sulfa use, fluoroquinolones, et cetera. And then they also had a bit of a heat map in their study to give a sense of which of from the 14 health regions in Ontario, kind of what the general dispensing rates were of antimicrobials. The Essex, Lambton, Sarnia area, where I'm originally from, kind of had the highest reported rates for their particular study period. Currently, I'm involved in a deliverable back in Manitoba with the Manitoba Centre of Health Policy. It's funded by Manitoba Health. The MCHP is really an incredible resource. It's a large data repository that has data sets not only from health, but from social stuff, welfare services, justice. So it's really a great resource, and it's all linked by the Manitoba FIN, which is like our unique provincial identifier. So it really affords you great opportunities to do population research. So we received funding to do, let's go back. No, there's a slide missing here, but you can still get the idea. So basically, it allows us to link by billing codes with antibiotics prescribed by age group, by regional health authority in Manitoba. We can link potentially side effects from antibiotics in terms of subsequent emerge visits or other types of medication prescribed. We have not seen really a drop in overall antimicrobial use in the province. We can break it down by type of agent dispense. So this is your beta-lactam, beta-lactamase inhibitors like amoxiclav, and we've actually seen a bit of an increase in older patient population over time. We can also break it down, at least with the last few years, by type of prescriber. So remember what I was saying earlier about rates in non-physician prescribers. So for our entire study time period, we've seen just under 10% prescribing rate in dentists, and this has gone up, I would say, a few percentage points every year during the study period. And then we can link it back to diagnostic billing codes that were submitted by the physician, and I've kind of bolded for you some of the kind of highlights. So a lot of these are really, well, these are all conditions where generally we would encourage physicians not to prescribe antimicrobials routinely, so upper respiratory tract infections, viral pneumonias, so this is a physician that's submitting a billing claim, a diagnostic billing claim, a billing claim for viral pneumonia. Acute bronchitis, lots and lots of educational initiatives over decades, really saying that acute bronchitis should not be treated with antimicrobials, but still our rates are very high. And lots of studies recently in human medicine saying that you do not need, for particularly ambulatory acute exacerbations of asthma, you do not need to prescribe antibiotics. And even though our rates have gone down, we're still talking 10, 15% prescribing rates for asthma exacerbations in some patient populations. Thinking globally, this is a very recent study in the Lancet Infectious Disease, where they took wholesale antimicrobial sales across 70 middle and high income countries from 2015, and really got a sense focusing on pediatric data, and really grouped them by category of drug. So they called it access versus watch versus reserve and unclassified. So you want more green, as much green as possible for your country. So they're the narrower spectrum agents. And you can see there's a lot of variability. Countries on the left, the top prescribers there are countries like Holland, Slovenia, Spain, and on the opposite end, you've got countries like India, China, Bangladesh, Saudi Arabia, Canada and the US, we're one right behind the other. We're about position 6 or 7 towards the left-hand margin. Not all prescribing is equal in the type of setting where you practice. So historically, a lot of this has been in your traditional doctor's medical office, but you have to think about other places: urgent care centers, emergency rooms, retail clinics. Urgent care centers are, I guess, kind of like an emerge, but for less acute conditions. Retail clinics are the little walk-in clinic where you could go to inside a Walmart or inside a superstore, that sort of thing. This was data, again, from the United States, where they looked at submitting billing data by inappropriate prescribing. And what they saw, of course, is a lot of variability, but really the highest rates of inappropriate antimicrobial prescribing in these urgent care centers. This study that was just hot off the press within the last couple of weeks from the United States looked specifically at pediatric emergency rooms. Important because 1 in 5 kids every year go to the emerge for a visit and often results in an antimicrobial prescription. In their study period, they saw over 90 million visits by kids to various types of emergency rooms. They broke it up by kind of pediatric-specific emergency rooms and those that were not specific for children. The bulk went to non-pediatric emergency rooms, so as part of a larger adult facility. Unfortunately, what they saw is a lot of antimicrobial prescribing that was overly broad, more macrolide therapy, generally for diagnostic criteria, which we don't typically prescribe antimicrobials, and lower rates of that guideline concordant first-line recommended therapy in a lot of these centers. So really something to think about, and this is just a graphic representation of this, something to think about when you're targeting stewardship initiatives, to really think about the messaging to non-pediatric emergency rooms. And then something, when I was putting this talk together, I had never thought about. I don't think this maybe exists too much in Canada, but more so in the US, this direct-to-consumer telemedicine. So this is like an online portal. You basically go into the virtual waiting room, and then you see a physician electronically for whatever your condition is, and they manage you online. This particular company kind of went over their experience over a couple years with respiratory tract infections. They saw almost a 2/3 prescribing rate for assessments for respiratory tract conditions. And with all these visits, physicians get rated by the clients that they see. And what they saw, not surprisingly, was that physicians who had the highest rating scores tended to be the highest prescribers of antimicrobials, and most often inappropriately. Well, you might say maybe some of the times these are tricky conditions to diagnose. You might take something like sore throat or pharyngitis. That is most of the time a fairly straightforward illness when it comes into the office. But we know from a lot of studies, say even in adults, only about 10 to 15% of pharyngitis, usually due to group A strep, that may require antimicrobials. But again, you can see from over time, with extensive messaging, our rates of prescribing have not really changed. And this is, of course, where stewardship programs come in. I like to call them, when I have fellows rotate through, I like to tell them that these are really support teams or assistant teams. I went to a conference last year and someone said, we're almost like antibiotic sommeliers. We try to mesh the right antibiotic with the right diagnostic criteria. And I'm like, that's a fantastic way to define it. I'm going to steal that. I think the important thing to remember, I think similar to vet medicine is with us in humans, is that there's Really no one size fits all. You have to tailor it to your particular circumstance, whether that's inpatient or outpatient. This Venn diagram kind of gives you a sense of where the patient sits in stewardship, more so probably in an inpatient setting. So you've got the physician and clinicians on top. You've got your infection control prevention people, your diagnostic people in the lab. IT, data analysis is very important. So really kind of using all these people to promote this idea of a program of safety and quality. The various strategies that we use, kind of this audit and feedback, where you audit the prescribing or behavior of a group of clinicians and provide them with either real-time or periodic feedback. Restrictive policies like pre-authorization, that's more so in the inpatient setting, and then various other things that we can use, switching from IV to oral programs, kind of discouraging people to use antibiotics which are associated with high rates of C. diff disease. And then kind of other supplements, although not things that are necessarily recommended first line or as standalone. They are really still good strategies that you could incorporate into your stewardship initiatives. So very briefly, we had a pilot program that we did at Winnipeg Children's Hospital where we did audit and feedback to our medical ward teams in the ICU. We only had funding for about a year to be able to do 3 days a week, and since we didn't get funding afterwards, we had to really curtail our efforts. But we had little clinical care guidelines that we submitted, little educational things, kind of cool little posters like this, that having a wife who does graphic design, it really helps to be able to do these sorts of things. And what we found after, so the top is wards where we worked, the bottom is wards where we did not work. The three boxes in each row, so we have pre, during, and after. So if you look at the top, so you see this is like our days of therapy of antibiotics in the hospital. So you can see a lot of variability. So variability is bad when it comes to stewardship. And then when we were active, it took a few weeks, and then we really kind of leveled out. And then almost as soon as we went inactive, it reverted back to the kind of bad behavior. So really these educational things, they continued even after we were done. So really not something, well, education is important. Choosing wisely in the US, there's all the Get Smart stuff. It's important, but human behavior is such, and especially when it comes to stewardship, that really as a standalone thing, it's not something that is really, that can be maintained in the long term. And if you ask a lot of physicians face-to-face, would you prescribe antibiotics for a viral infection? Most of the time they're going to, well, hopefully they're going to say no. So it's hard to argue that it's a lot of the time it's a knowledge issue. I would probably want you to consider that a lot of times it's more of a psychological problem rather than a knowledge issue. So I think this little editorial is a good synopsis of this, and really thinking about the push-pull of prescribing antibiotics, not prescribing antibiotics, that really weighs on a prescriber's mind. So the first things are things that are like pulling people towards prescribing antibiotics. Really, that decision is made in the here and now. And I will email my slides out after if people want them. The belief, real or not, that the patient wants antibiotics, it's much easier just to write the prescription and be done with it than to take the time to explain, or it's the way you've always done it, or it makes you feel safe, or by doing it, you're avoiding something bad. In contrast to the withholding an antibiotic prescription, they're not really salient. They're in the future somewhere in the prescriber's mind. So all those risks down the road of resistance, adverse drug events, or following guidelines, which a lot of people think are just set in the ivory tower. So if you think about inappropriate antimicrobial use as a psychological problem, stewardship interventions really have to aim to change clinician behavior, which we know is very notoriously, it's a hard thing to do. But even we know that it's hard to do, we know that a lot of the inpatient stuff, when it's suggestive, it actually does meet with a reasonably high success rate, about 3/4 of the time. For us, it was about 70% uptake rate. But even our persuasive stewardship initiatives could be more persuasive. I think if we had a better sense of some of the behavioral interventions that we could do, and I know some of the speakers later in the conference will speak more to this, but I think we also have to be cognizant of the fact that antibiotic prescribing is not just a knowledge thing, it's, you have to think about the social factors that go into this. So just to wrap up with, I'm just going to touch on these things. So some very nice studies which have described this phenomenon, and I don't know if this exists in vet medicine, but this prescriber etiquette, this strong norm of non-interference. How a team works in an inpatient setting, you've got the attending physician, you've got the senior resident, you've got junior residents, you might have junior on-service residents. So if it's a ped service, there are pediatric junior residents, but then there might be family medicine residents, then there are medical students, then there might be PA students. So it goes kind of that hierarchy of prescribing. And who makes the decision about what to prescribe and when to prescribe and how long, and who deals with the side effects of it, who seeks approval for the drug if it's restricted, really is quite variable. And I see this even on the infectious disease service. People are hesitant to drastically alter the therapeutic plan of a previous colleague unless it is immediately harmful to that patient. We as clinicians are very reluctant to both receive constructive criticism from colleagues, but also to provide that criticism, that feedback, I should say, to colleagues. Common things we hear is that my patients are different. My patients are very demanding. They want antibiotics. That's bogus. Lots of studies have shown that the amount of times that people actually come into the office and say, I want antibiotics, is single-digit percentage of the time. There might be a more indirect body language type things, but the actual times they come out and say they want antibiotics is actually very, very low. We talked about time-consuming issues in prescribers' minds. Sometimes there's a fear of litigation. If they don't prescribe it, there's a bad outcome. We as clinicians are really poor judges of perception of what families really want. When you look at the studies, what families, what parents say they really want from the clinician is not necessarily a prescription for antibiotics. They want reassurance. They want empathy. They want to hear that you hear them. They want to hear about symptom management, what the plan is. Not like, oh, if it gets worse, come back. And they want to be involved in the decision management. So clearly there's some parents in the family. I won't show you any of these videos, but when you have time, check this out. This is fantastic. This is from Seattle Children's. Dr. Margione Smith is a pediatric ID physician, where they have done these evidence-based behavioral feedback initiatives where they're very structured on how we provide feedback to families, to parents, and it makes a huge difference in the time of the clinical encounter, the amount of time that parents change their messaging to actually ask for antibiotics, and the rates of prescribers actually giving antibiotics. We are also poor judges of risk. We a lot of time believe that if we don't treat, the risk is much higher with an uncertain diagnosis than if we withhold antibiotics, even for the short term. We feel that by giving a bigger gun antibiotics, it is safer than giving narrower targeted therapy, and that by giving some antibiotics, it will avert all bad things from happening, and I don't have to see the patient again while I'm on call, and I can go to bed. Perception of the problem, it's not me, it's everyone else. I'm exceptional to all the other prescribers out there. The guidelines don't apply to me. They're made in the ivory tower and not grounded in any clinical day-to-day reality, and that even antimicrobial resistance, it's a macro issue. It's a theoretical issue more than anything. So I'll just show you my last couple slides. Before we rolled out our stewardship program, we involved all our faculty in the Children's Hospital in kind of helping us to design it. So we got a sense of their attitudes about antimicrobial prescribing. So look at this question. Antimicrobials are overprescribed to kids in Canada. How much do you agree with that? The very next question in the Survey Monkey was Winnipeg. So what do you think happened? Boom. Here's the two questions back to back and how they answered. So they went from 90% agreeing with that in one form or another to less than half. And when I do this talk for other audiences like OBGYN and family medicine, I get the same spectrum of answers. Being married to a family physician, I entirely understand the time pressures that people are under. In some scenarios, the ability to watch and wait is not there. The patient volumes that a lot of practitioners see, it doesn't facilitate easy discussion. This is a little time of day study where they noticed that rates of inappropriate antimicrobial prescribing went up as the day dragged on. So maybe there was some decision fatigue that just, it was easier to prescribe rather than think about it or explain it more. So, I think if I had to summarize understanding antibiotic prescribing in humans, there's a lot of it all over the place by many different prescribers. We have to think really beyond the typical physician in a white coat in the family doctor's office when we think about who is prescribing. And I really think over time now, we have to focus on better understanding more of the behavioral, social aspects. So the attitudes behind prescribers, what their motivations are, thinking about it at the local level, because prescribing in Winnipeg clinics are going to be very different than in northern Saskatchewan, and really to think about how we might incorporate new knowledge, new strategies, new technologies in stewardship plannings while still maintaining that face-to-face human interaction, which a lot of people tell us that is what they appreciate the most behind antimicrobial stewardship plans in humans. So thanks very much. I apologize for going a few minutes over, but I think now we'll do some questions for our panel.